Okay, clinical case scenario. This is a very important subject, especially for exams, where the students are expected to interpret the data given from the patient. It's also important for students clerking patients to interpret the signs and the symptoms that they obtain from the patient and coming to a reasonable and logical diagnosis. Okay, the history, one of the most important component of the history is the chief complaint. Okay, the chief complaint is the complaint that brings the patient to the doctor or to the hospital. Okay, so after the chief complaint, you list down all the list of the possible causes that are in this patient for his chief complaint. So it can be as many as possible. And from this list of complaints, subsequently, with the history of present illness and the physical examination, we will exclude one by one whatever diagnosis is not feasible, so that by the time we come to the diagnosis, we can have just a couple of them as for differential diagnosis. Okay, so from the history of present illness, you look for the issues or pointers from the history. You list the positive and the relevant negative symptoms, and at the same time you also make a list of what are the data you may want to know further from the patient. Okay, from the list of positive and relevant negative symptoms, you list the possible diagnosis from the info you have got from the patient, and then exclude some of the causes from the list prepared after the chief complaint. Then you go to the examination. The examination is the same. You look for the issues or pointers from the physical signs that you got from the examination. List the positive and the relevant negative signs in the patient, and list out whatever signs that you may want or need to look for in the patient further. After this, you decide what diagnosis that you can exclude after the signs that you obtain from the physical examination. That is, to eliminate some of the diagnoses from those that you have listed after the history. Okay, after the history and the physical examination, you make a clinical summary of your patient's problem. Okay, the summary of both history and physical examination. It should be short, if possible, within the 5 sentences. It should include history and the examination, and should be mainly of positive symptoms and signs, plus the relevant negative symptoms and signs that you have got. With this summary, you then consider the diagnosis. You come to the most likely diagnosis, or the provisional diagnosis, which is only one. And this provisional diagnosis must be based on the symptoms and signs alone that you get from the case scenario or from the patient. And this diagnosis must be common and prevalent and relevant to the case. At the same time, you also have a couple of differential diagnoses, which are other possibilities. It would be wise to consider at least 3 other possible diagnoses for every clinical case summary. After you considered the provisional and differential diagnosis, then you think or consider the number of investigations that should be done to confirm or exclude your diagnosis. This should be routine baseline investigations, especially of blood and urine. Then you have the diagnostic blood investigations, example serum amylase, troponin T, which are very specific for acute pancreatitis and acute myocardial infarction respectively. Then we have the imaging techniques, which include the plain X-ray of the chest or abdomen, the ultrasonography or ultrasound scans, the CT scans, MRI and MRCP, ERCP, endoscopy, upper and lower GI endoscopy, and special tests such as the angiogram and venogram as and when they may be required, and finally tissue biopsy, which can be the FNAC or true cut core biopsy. Then these are the summary of the 10 steps to a diagnosis. Get the chief complaint, consider the common possible causes, get a detailed history in relation to the chief complaint, list the possible symptoms and the relevant negative symptoms, list the possible diagnosis from the history, then examine the patient thoroughly and list the possible positive and relevant negative signs. Then you come to a clinical summary, make a clinical summary, and then consider a number of differential diagnoses and one provisional diagnosis. At the end of this clinical steps or clinical measures, then you come to review the investigations done on or you would like to do further. And by reasoning and by exclusion, determine the final diagnosis in this patient. After the final diagnosis is made, it is usually after all the investigations and reports are obtained. Tissue diagnosis, biopsies where possible, or diagnostic tests where relevant, in cases where biopsy is not possible. The treatment can be either curative or palliative, which has to be considered after the final diagnosis, which usually consists of medical and pharmacological. Then the surgery, which can be either endoscopic, minimally invasive, or open surgery. And of course, the last is not the long-term management of the patient. As for the students, or in fact even for the doctors, you must have some learning objectives of this process, in the process of going through this case scenario or the patient in question. What were you expected to learn from this case? Did you achieve your target? And last but not least, what more have you got to do to improve yourself further in this group? Now I'll go through a case to illustrate as an example of how a case scenario is dealt with. This is a case scenario of a man with right-sided abdominal pain. Okay, a 24-year-old man presents with a 2-day history of abdominal pain. Okay, The pain started, the central abdomen became constant, shifted to the right iliac fossa. He vomited twice and is off his foot. His motions were loose today, but there was no associated rectal bleeding. On examination, the patient was in slight pain and had a temperature of 38.2 degrees and a pulse rate of 110. Examination of the abdomen revealed a flat abdomen that moves well with respiration. He had localized tenderness and guarding in the right iliac fossa. Okay, now we analyze this history for this case scenario. The chief complaint is a 24-year-old man with a 2-day history of abdominal pain. Okay, now with this we consider the possible common causes of acute abdominal pain in a 24-year-old man, and the list here includes some of the common causes, among which the most common will be acute appendicitis, acute gastritis, acute gastroenteritis, urethral colic, acute pancreatitis, acute cholecystitis, and peptic ulcer. Okay, then we go to the history of present illness. Those highlighted in green are the positive symptoms: central abdominal pain, then it is shifted to the right iliac fossa, radiation of pain, vomited twice, and he has not been able to take his food. Okay, his nausea and anorexia. He had loose motion once. The purple colored highlights are those with relevant negative symptoms, which include rectal bleeding, no urinary symptoms, does not drink or smoke, and he was healthy before. Okay, now what are the pointers from the history and of present illness? Positive symptoms: abdominal pain, 2 days onset, vomiting, radiation from central abdomen to the right iliac fossa, loss of appetite, and loose motion. The negative symptoms were no rectal bleeding, no urine symptoms, no drink or smoke, and was an otherwise healthy man. To get further information, we need fever, vomiting of blood or coffee ground, whether there is any urine symptoms, which is given, there's none. Okay. Possible diagnosis from the history are these 4 conditions: acute pancreatitis, acute appendicitis, acute pancreatitis, acute cholecystitis, and AGE. Okay. From the history, we have excluded excluded the right urethral colic, as there were no urinary symptoms and the pain was not in the right loin. Also, acute gastritis is unlikely because the location of the pain is not in the epigastric region. Then we go to the physical examination. Again, the green highlights are the positive physical findings. His patient was in pain, had a temperature, and is tachycardic. Tenderness and guarding in the right iliac fossa. These are the positive signs. Whereas the negative signs, relevant negative signs will be no pallor or jaundice, abdomen is flat, and it moves well with respiration. The abdomen was soft and tender over the other areas. There were no masses, and the liver, spleen not palpable. Again, using the after the physical examination, we have listed down here the positive signs: pain, patient in pain, fever, tachycardia, localized tenderness in the right iliac fossa, and guarding in the right iliac fossa. Negative symptoms, signs were no epigastric tenderness or guarding, no lumbar tenderness, flat abdomen, Rest of the abdomen was normal. Liver and spleen were not enlarged. We want to know a bit more about what are the other signs. Will be jaundice, whether he was jaundice, whether there was pallor, and we would like to know about his hydration status, which are not provided in this case. Okay, after the physical examination, the possible diagnosis that is left behind will be acute appendicitis and possibly acute cholecystitis. As the excluded diagnoses include acute pancreatitis and AGE. As there were no signs of peritonitis and the tenderness was very localized to the right ilia fossa. So we make a short summary, we give a clinic summary of 5 sentences, which I think is more than enough for this patient. First, 24-year-old man with 2 days history of abdominal pain. Then the nature of pain, central abdomen related to RIF, associated with loss of appetite and vomiting. And on examination, he was febrile, tachycardia with marked tenderness localized at the right ilia fossa. So that leaves a provisional diagnosis of acute appendicitis with the differential diagnosis of acute cholecystitis, acute pancreatitis, which are rather unlikely compared to acute appendicitis based on their location and of the pain and tenderness. Okay, next we carry on with the investigations. In the investigations, white cell count is high, so there's leukocytosis, and there is reactive protein is raised, C-reactive protein, which suggests an inflammatory cause and probably inflammatory and infective cause. So we need the serum amylase, urine analysis is normal, ultrasound and abdominal pelvis. We assume these are normal as they were not told to be raised. As such, based on this, our diagnosis will be either acute appendicitis and acute cholecystitis and acute pancreatitis would have been excluded. So the final diagnosis left behind is acute appendicitis. So this is a scheme which I propose, which is simplified, simple to be used for by the medical students to solve any clinical case scenario of surgical cases. So here once again a summary of the 10 steps to establish a diagnosis. Get the chief complaint and consider the common possible causes. Second, get a detailed history in relation to the chief complaint. List the possible symptoms and the relevant negative symptoms. List the possible diagnosis from the history. Then examine the patient thoroughly. The 6th step, list the positive and relevant negative signs and findings on physical examination. Step 7, clinical summary and a diagnosis, provisional diagnosis is made. A few differential diagnoses are provided in step 8. In step 9, you do the investigations, review the investigations done, and do whatever you would like to do further. And in the last 10th step, by reasoning and by exclusion, determine the final diagnosis. This, ladies and gentlemen, is my simplified version of solving the clinical scenario puzzle.